Bismillah ar-Rahman ar-Rahim. Hello and welcome everyone. I am Muhammad Sama. I am a medical student in Medicine College, fifth year. Today we're going to talk about the most fundamental and important topic in medicine, which is basic life support. It's my distinct honor here to present to you Dr. Muhammad Siddiq Shahid, a cardiologist and assistant professor in Sulaiman al-Rajhi. He will discuss with us the introduction to the basic life support and the technique and how is it applicable in the all of our life. Dr. Muhammad, you're ready to go.
Bismillah ar-Rahman ar-Rahim. Thank you for the lovely introduction, Mr. Osama. It's a pleasure to be here. All right. I think that one can never, understate the importance of basic life support. We all became physicians, and we are in this journey to save lives. And this is one of the basic steps that we all need to be, well appraised of when we consider, the process of saving lives. What I would like to do is basically, I've got a PowerPoint presentation. And it would be nice if you can directly share that. I'll try if I can, start off the sharing, right? What's actually happened that the screen that was available initially, the full screen, it has gone, and you can see a small actually screen. And I'm just looking from where I could share. Let me just have a look. Okay. Osama, can you help me out with this? Hello?
Yes.
Yeah, I can just see the small screen, the big hangout screen. It's gone, and I can't see where I start out sharing the PowerPoint. Can I, kind of reconnect again with the Hangout?
Just go back to the link and then come back, no problem.
Yeah, I think I got it right. Okay, so I'll go for the entire. Right, here we are.
Okay, it's up and ready.
Up and ready. Good. Okay, right. I think one of the best ways to start off this discussion would be the reference from the Holy Quran, and the English translation of the ayah says, "And whoever saves life of one person, it is as if he has saved the life of the entire humanity." So, as I said, we really cannot understate the importance of basic life support. What are we going to discuss in this, 45-50 minutes is what basically is BLS and what is CPR? What do we mean by both these terms? What are their significance or importance? And we just want to go through the techniques of delivering an effective BLS in an adult. You would have to understand that BLS is a psychomotor skill. It's a motor skill that we learn, and it's basically the technique is learned and refined in a course in which one interacts with mannequins and volunteers. But we want to have an introduction to the physiology, the basic physiology, and the steps of BLS. So a presentation can never be a substitute for an actual BLS course. And we just want to have an idea of what's the awareness of BLS around us in the society. So basically, to start off with clarification about some abbreviations. So BLS, as we all know, stands for Basic Life Support, BLS, and CPR stands for Cardiopulmonary Resuscitation. Now, CPR is basically a part of basic life support, as we will see. Right, it's always nice to contemplate the history of a process. So it starts way back in 1740. I wouldn't take too much time on this. The Paris Academy of Sciences officially recommended mouth-to-mouth resuscitation for drowning victims initially in 1740, and there have been certain landmarks. 1891, chest compressions were documented officially. 1960, the American Heart Association started a program to acquaint physicians with closed chest-to-chest cardiac resuscitation. That was the start of CPR. In 1972, it was the medical fraternity realized that CPR has two aspects: one in a medical setting within medical facilities, and its importance in the public. The public needed to be trained, and in 1972, the first mass citizen training for CPR was held in Seattle. The conference was actually the workshop. It was a mass workshop. It was called Medic 2. So the shifting of training of BLS or CPR from the paramedical health staff within health facilities to the general public, the process started in 1972. In 1992, we have the landmark foundation of the International Committee on Resuscitation. It's actually ILCOR, and this foundation, this committee actually takes input from all other organizations, and it is responsible for laying down the guidelines for CPR and BLS. And by the way, we have the latest recommendations in 2015. Now, I just was wondering if I can have a bit of input from the audience, if I can ask the colleagues here with me or students, is do they have any idea what is the percentage of the population in KSA in our local setting where we are who have an inkling of what is CPR and maybe on how to apply it? Can I have any input from any of the people, the audience, the colleagues sharing with us?
You
Anyone?
mean,
Yes.
you mean how many have you updated before?
Yes, I mean the gentlemen who are with us and the ladies who are attending with us. Any idea on if they have any idea on what is the percentage of population in KSA that has an appraisal on what is CPR or might be, trained to implement a CPR?
Anyone have an idea?
Hassan is there, and I know Sadi Al Jundi is there, and I know Qutaiba. These are the people I know. So if any one of them has any idea, please can we share it? Okay, right. Now there have been studies in King Saud University and Qasim University. On yes, we can hear you.
Yes. Are you asking about the percentage of the students?
Okay, this is Abdul Waris, if I can recognize him correctly. Yes, welcome, Abdul Waris. I'm just wondering, yes, the general awareness of the public on what is CPR. I mean, not students. That any idea on what's the basic percentage of people who would be in a position if they see a situation arise, and they would be in a position to maybe to start a CPR.
Okay. Because when I was doing the BLS, I heard from one of the trainer over there that
The voice is not clear. Would you please raise the voice?
Yes, Abdul Waris, you might need to raise your voice, please.
yes, okay. I am saying that one of the trainer when I was doing the BLS, he told me, and I asked him this thing that you see that the population in US and UK, they are very much active, and they are very much aware of this thing, that when a situation arises like this, so they have to perform like CPR and all of these things. But the population here is very less who knows about it. So that is why you see that every student and every intern over here, he has to do this.
Okay, so
I totally agree with him.
so I think we'll all agree. Statistics have there are studies that were done among the paramedical staff and medical students, and I really don't want to quote any numbers, but they were quite dismal. I mean, even the medical fraternity or students, paramedical staff, the training was, or the knowledge about CPR, effective CPR, was less than a third. So we can, consider, extend this to the general public. So we have to understand the situation that the awareness on CPR needs to be, developed, and we all need to learn CPR and maybe, make the public aware of it. The problem with CPR and BLS is, and the issue with this is that most of the people who collapse or who need CPR, they do so outside the hospital environment, right? And most of these victims were previously, relatively healthy and had no serious underlying, non-serious underlying heart conditions or other conditions. So they had an unexpected collapse, and mostly this collapse will take outside the hospital environment. In the US, I'll just go back to my slide. Well, in the US, these are statistics that's about 3 years old. 300,000 out-of-hospital sudden cardiac arrests occur annually, and 88% of these cardiac arrests occur at home in a domestic situation. And most, as I said, many of these victims are apparently healthy with no known previous heart disease or risk factors, right? Now, in a situation like this, where the requirement for CPR or BLS, that is a cardiac arrest or a respiratory arrest, occurs at home most of the time, the life one may be saving with CPR is most likely to be a loved one. And if you are called on to administer CPR in an emergency, the life you might be saving or attempting to save is likely to be someone at home. It could be a child, a spouse, a parent, or a friend. So that makes it very important and imperative that we learn CPR and we train in CPR. Okay. Now, can anyone? I have an audience for medical students. When would CPR be indicated? What would lead to an arrest? What type of acute illness would lead to an arrest? Cardiac or a respiratory, or when would the need arise? Can anyone maybe chip in and give their ideas?
Hypoxia, fatigue.
Yes, anyone? What would, when would the situation arise that BLS or a CPR would need to be, implemented?
I think if you're asking about the cardiac causes, there could be ventricular fibrillation or ventricular tachycardia or asystole.
Okay, these are cardiac causes. Very good. Yes.
And other than that, if the patient has drowned, in a sea or in a place like this.
Right. So drowning is a cause. So you could have pulmonary causes, you could have cardiac causes, and of course you have obstruction of the airway.
Yes.
So cardiac causes could be cardiac arrest. It could be cardiac standstill. It could be cardiac arrhythmias, tachyarrhythmias, ventricular tachycardia, or fibrillation. And pulmonary causes could be obstruction of the airway, of a major airway, drowning, very important. People are very fond of visiting swimming pools in summer. It's very hot over here, and people generally do that. It's a well-developed, cultural and social habit. So you would have basically the need to administer CPR in a cardiac arrest or a pulmonary obstruction, airway obstruction, right? So what is the goal of the BLS? What do we want to do? What do we want to achieve? We want to basically support the oxygenation process, the ventilation process in the patient, and circulation until there is return of spontaneous circulation, which ROSC, ROSC in brief, or advanced cardiac life support intervention can be initiated. So we have to be very clear on what we are planning to offer, or what is our aim while we are doing the BLS. What is the goal? So we want to support three things. We want to maintain the oxygenation, that is the distribution of oxygen to the peripheral tissues. make sure that the ventilation continues, that is the delivery of air to the lungs, and circulation continues, that is delivery of the blood throughout the body, until the patient becomes spontaneously, recovers circulation, or further advanced intervention can be done. It does not include advanced interventions like placing an endotracheal tube or giving any drugs. So BLS is very different from ACLS, and it has got a limited but very useful aim. So I want to start off with maybe what does BLS. There are three major components of it. So the first step is you have to comprehend that the patient needs basic life support. You have to recognize the requirement of BLS. You have to have an immediate recognition of sudden cardiac arrest. Secondly, you want to activate the emergency response system, which could be calling 911 or sending someone for help. And third, you want to start a cardiopulmonary resuscitation and involve the automatic external defibrillator in the process. So three steps: recognition of the situation that the patient needs CPR, BLS. Secondly, activation of the emergency response system. Thirdly, you want to start off early CPR and plan on defibrillating the patient with an automated external defibrillator. For patients who have collapsed or who have undergone cardiac arrest, there's something called as the chain of survival. Hopefully the students would know about it. And this chain of survival is basically the individual steps that work together to increase the survival of the patient. So the first step, the first link in the chain is early recognition and calling for help. So that's the first step. Secondly, you start the CPR, chest cardiopulmonary resuscitation with chest compression and ventilations. And third step is early defibrillation. And the fourth step is once the patient is stabilized, there is post-resuscitation care. There has been a revolution basically in BLS with the introduction of this early defibrillation. You could continue CPR, cardiopulmonary resuscitation, and you could continue with chest compressions and ventilation. In the previous guidelines, the availability of early defibrillation was not there. This has been incorporated into the latest guidelines. So, can anyone tell us the steps of CPR? Anyone, please?
The steps of CPR, you mean like how we have to approach the patient?
Yes. So
so it's airway, breathing, and circulation.
Okay. So it's ABC. Is the famous
ABC? Yes.
ABC. Yes, isn't it? Airway, breathing, circulation. Prior to this, actually, before you basically start airway, breathing, circulation, you have to, as you said, approach the patient, and actually you have to become alert to the fact that the patient needs BLS. The patient does need life support. So how do you ascertain that? Can anyone enlighten us on that? How do you ascertain that you need to start off ABC?
As far as what is written here, we have to awake him, and if he is not responding, we'll tap him by verbal, and if not, start the CPR.
Okay, very good, very good. So I think what typically would happen is either you would the responder might come up to an unresponsive patient, see someone already collapsed, in a collapse situation, lying down on the floor, and so that would be one situation. The second situation would be you would actually witness a collapse. So a patient who's maybe up responsive would suddenly become non-responsive. So you have something called as witnessed collapse and an unwitnessed collapse, right? So in both ways, you want to make sure that the patient is not responsive. The patient actually needs BLS. What are the situations in which the patient would apparently be, non-responsive and would not need BLS? What would be the situation?
Situation that the patient would not need BLS?
Yes, that the patient is not responsive, is apparently is collapsed, but does not need CPR, does not need BLS.
In coma situations? Is it in the coma situations?
Yeah, which situations, please, Osama?
Coma
Okay, very good. So the patient might, yeah, it's neurological collapse. Okay, so the patient might be in coma, might have had a stroke, right? And stroke does not require CPR or BLS, right? And what's the, I mean, coma, you apply the GCS, Glasgow Coma Scale. That would be it would take some time. But what about a patient who's, drunk, maybe under drugs of effects of drugs, okay? Right?
As I said that he's breathing and he's half pulse, then there's no need for CPR.
Yes, exactly. So you basically want to make sure that the patient is unresponsive, but that the patient being unresponsive is not enough.
Yes.
Right. So what you would do is basically you start off by look around and ascertain the safety of the scene. So once you enter a situation in which someone has collapsed, it could be a roadside accident, it could be electrical injury due to electric current, it could be faizana, this you have flood, water, the patient is, you have pulled him out of the water, okay? So make sure that the scene around you is safe. You look around and ascertain the safety of yourself and the patient at the scene, right? Secondly, you will check the responsiveness of the patient by shouting, "Are you okay?" Right? And you would tap the patient on the chest. You would tap the patient on the chest briskly and sharply and ask the patient if he's okay. Right? Now, if the patient does not respond, so the response could be any of these. The response could be the patient might respond, by moving part of the body. The patient might blink. The patient might have a verbal response. Okay. So once you get a response, you would not start BLS or CPR. Okay. If after shouting, "Are you okay?" and tapping the patient on the chest, you do not get a response, then you observe the victim for breathing for 5 to 10 seconds. So you look at the chest for any movements. If the respirations are present, the victim should not be attached simply to a cardiac monitor. If there are no respiratory movements after 5 to 10 seconds, you should activate the emergency medical services by calling 911 or asking someone to call 911 and asking the person to retrieve the AED if available in the vicinity. Okay? Right. So step 1, ascertain your own safety and the patient's safety at the scene. Kneel beside the patient. Shout, "Are you okay?" If no response, tap the patient on the chest briskly. If there is no response, observe the patient's breathing for 5 to 10 seconds. If there are no respiratory efforts, there are no respiratory movements, that means the patient needs CPR. So you activate the emergency medical services and you send someone to get the AED, or if you know that the AED is available, you would want to get it yourself. Right? Has anyone heard of the agonal gasping respiration? Has anyone witnessed a cardiac arrest in a hospital setting? Anyone of the audience?
Sorry, would you
repeat my question? Yes. Has anyone witnessed a cardiac arrest in the hospital setting? Has anyone witnessed?
No, but we read about the agonal breathing.
Okay, excellent. So this is exactly what I wanted to point out, that agonal breathing, these are effort at just simple gasping, okay, gasping respiration that the patient makes because of stimuli originating in the brain stem, in the respiratory centers. These are not effective respiratory movements. These are just the patient will be gasping. One of the common mistakes made during CPR is people would ascertain these gasping respiratory movements as effective respirations. These are not. So one should clearly recognize these gasps for breathing. Do not consider them as effective breathing, effective respiration, and start the CPR. Is everyone clear about it? Any questions?
So as soon as we see someone gasp, we start the CPR.
No, we have to understand that agonal gasps or agonal efforts on respiration are not the same as respiratory movements, are not the same as respiratory efforts. Okay.
Yeah, I understand now.
Yes, a patient who has collapsed would have respiratory electrical activity in the respiratory centers in the brain, and there would be gasps, but these will not be effective at the respiration. They would not be effective in moving air into the lungs and expelling them.
Yeah, I got it.
These are agonal breaths, and this should not be equated with respiration. Right. So, despite if you see if the responder is seeing these agonal breaths, these do not mean that the patient is breathing. These are just electrical stimuli from the brainstem, just making respiratory movements. They are not effective at respiration. Okay, right. So you have to come in within your own safety and the patient's safety. You have check responsiveness of the patient by shouting, "Are you okay?" and tapping the patient on the chest. You have observed the victim for breathing for 5 to 10 seconds, and there are no respirations. Now, I just want to, make something clear over here. The ABC of CPR in the latest guidelines has been changed slightly. It's become CAB. Is anyone aware of this?
Yes.
Okay, that's it. So I've got an updated audience. So anyone has any idea why this sequence was changed by ILCOR in the latest guidelines?
Because I think the most priority is that to keep the circulatory running. So as soon as we make a delay for the to start the circulatory, then it will be more problem. So the most important thing is that to check this the circulation is running.
Okay, okay, that's good. Anyone wants to add to this?
Actually, I believe that the main thing is that whether there are oxygenated blood present.
Anyone?
Could you have the gentleman raise the voice? It's not very clear.
Hassan, raise the voice, please, or
Okay, clear now. So
We're having a bit of difficulty in hearing Hassan clearly, but I'm sure he's probably pointing out the evidence base behind changing ADC to CAB was that once a patient collapses, for a few minutes, the blood is still oxygenated to an extent. And even in the absence of effective ventilation or breathing, the oxygen that remains in the blood would be enough to sustain brain activity for the next few minutes. They would take it at around 4 to 5 minutes. So the priority was given to circulation, as pointed out by Muhammad Osama, that you can start off the chest compression, ensure circulation without worrying about the ventilation and the respiration or the airway for the first few minutes. The blood is already oxygenated by the last breath, and the oxygenation will be enough to sustain nourishment oxygen to the brain for the next 4 to 5 minutes. So the priority was shifted to circulation, right? But this is important when you see a witnessed collapse, when you see a patient who was breathing and suddenly collapses in front of you. In that case, this would be effective. In a case when you have come across a patient who's already collapsed, you do not know how long this patient has been in this situation. It could be a few minutes, and this advantage of the blood staying oxygenated for the first few minutes is not very evident in this case. So in a case of a witnessed collapse, you would go for CAB, in which you see the patient collapse in front of you. In the case of an unwitnessed collapse, it would still be, most workshops, most courses still maintain ABC. It would take some time before the CAB becomes effective, implemented in teaching uniformly all across the boards. Is this point clear, everyone?
yes.
Okay. Right.
Yes, it's clear.
Okay, let's get back to what was happening. We came upon a situation in which a patient had collapsed in front of us. We have a certain our safety. We made sure that the patient, the collapse could be, due to a coma. It could be a vasovagal syncope. It could be an epileptic fit. So we confirmed this by making sure that the patient is not responsive by shouting at the patient, "Are you okay?" Tapping on the chest briskly, and then observing the victim for breathing for 5 to 10 seconds. If no respiration is present, we will start the CPR, and prior to that, we will, if there is anyone around us, we'll activate the emergency medical services by calling the 911 and by attempting to retrieve the AED if we know it's available in the vicinity. The next step is checking the pulse. Okay, so we will check the pulse by palpating the carotid artery on the side closest to you. So if you're leaning beside the patient on the right side, you will palpate the right carotid artery. And if you're leaning on the left side, you will palpate the left carotid artery. Please do not palpate both carotids at the same time. The pulse should be checked for no less than 5 seconds and no more than 10 seconds. So please, placing the balls of your index finger and the middle finger opposite to the thyroid cartilage, just lateral to it, in the groove that is formed between the sternocleidomastoid and the midline, you would try to palpate for carotid pulsations. Not less than 5 seconds and not for a time more than 10 seconds. If there is a definite pulse, then you can proceed to rescue breathing. Presence of a definite pulse would mean that the patient has circulation. He does not need circulatory support. He needs ventilatory support. So you would directly go to rescue breathing. Okay. If the pulse is absent, that would mean that you would need to start off the chest compressions. Okay. Right. So if the victim does not have a pulse, then you start off chest compressions immediately at the rate of 30:2. 30 chest compressions directly to the chest. We'll just have a look at the technique. This will be punctuated by 2 breaths every 30 compressions. Okay, right. Okay. Again, I just have an interesting question. Has anyone actually seen CPR, whether live or in a video?
Yes.
Yes, we have seen.
Okay, so you have seen it in the video.
Yes.
Okay, I just have a question because I'm sharing the screen. So the slides change. Is it possible that by sharing the screen, if other people move their mouse or they press on the keyboard, that the slide would change because it's happening here?
No, it doesn't.
Okay, so somehow it's changing. So I think I have got a little hitch over here. Okay.
Oh, please,
Right. Anyway, let's get back to the question. So you might have seen a video. All of you probably would have seen a video on CPR and BLS, especially before this presentation. Okay. So so we decided that after looking for the pulse in the carotid area, if there is no pulse, you would start off chest compression. Okay. I have a question. If you find a patient in bed who has collapsed, can you start chest compression on that patient while the patient is lying in a standard bed or on a sofa?
Sorry, doctor, can you repeat the question?
My question is, if you see a patient who has collapsed, right, and patient is lying in bed, okay, on a soft surface, it could be a sofa, it could be a bed.
I think.
But the patient is still unresponsive.
Yeah, hello. Yes,
Yes,
anyone?
now it's okay. It's okay. It's okay. We apologize for the these technical issues. Okay, go on, doctor.
And my question was, we need to understand that we, for chest compressions, to perform effective chest compressions, we need the patient on a firm flat surface. The patient who's lying in bed, it would be not very useful to start the chest CPR on a patient lying in bed because when you perform the chest compression, you will not be able to compress the chest with the soft mattress that would give way with every movement of your hand, with the compression of your hand. So you need a firm flat surface. If the patient has collapsed outside on the pavement or on, so you place the patient flat on his back, okay, the chest is adequately exposed, so we need to expose the chest to look at the location for hand placement and to visualize the movement of the chest. Thirdly, we need to correctly position the hands with the heel of one hand in the center of the chest. So one hand in the center of the chest, the heel of it, and the lower half of the sternum with the other hand on the top. I have a video that will clarify this. So you start off by placing the heel of one hand in the center of the chest at the lower half of the sternum, and you place the second hand on top. Many people prefer to interlace their fingers together, right? Next step is your arms should be as straight as possible with the shoulders directly over the hands. So, and you need to lock your elbows, keep the arms straight to deliver effective compressions. The fifth rule is you give compressions hard and fast. So it's called hard and fast at a rate of 100 to 120 per minute. So it's hard and fast at a rate of 120 per minute. You want to achieve a compression of at least 2 inches in the chest. So you should be able to compress around 2 inches downwards on the chest. Another important thing to remember is that once you compress the chest, you need to allow the chest to recoil back. You need to allow the chest to expand. So I will repeat the step of high quality chest compressions. 1. Place the patient on a firm flat surface. 2. Adequately expose the chest. 3. Correctly position your hands with the heel of one hand on the center of the chest in the lower half of the sternum and the other hand on the top of it. Many people would interlace their fingers. 4. Keep your arms as straight as possible with your shoulders directly over the hands to promote effective compressions. 5. Give hard and fast compressions at a rate of 100 to 120 per minute. Aim for compressions of around 2 inches depth. Allow the chest to expand or recoil back between each compression. Anyone has any queries?
Yes.
Yes.
Yes, please. Go ahead, please.
Go ahead.
Go ahead.
One
One question.
I have a question, sir, if you allow me.
Yes, please. Go ahead.
What means to someone having cervical, let's say cervical accident? Should we move him from his place?
Right. So that's a very valid question. So it depends on the situation, Kutaiba. If you have the first aim is to keep yourself safe and ensure the safety of the patient. Secondly, so 2 things. So you have to look at the situation. If there has been a roadside accident, naturally you would want to gently move the patient away from the the road itself. Have the patient on the pavement. Secondly, if there has been an electrocution injury, the patient has received electrical injury, you would want to move the patient away from any bare wires that could still be a source of danger. If you're moving the patient out of water, you want to make sure that you pull the patient completely out of water. But saying this, you need to be very careful about patient's trauma. If there are injuries to the spine, to the cervical spine or the spine itself. So unnecessary movement of the patient, pulling the patient away or sliding the patient unnecessarily, you would avoid that. That's a very good question, Kutaiba. Anyone else?
Thank you, sir.
Okay. You would also want to make sure that if you find a patient who might be lying on his side or who might be lying prone, you want to gently roll the patient as a whole. So having your hands on the hip and the shoulder, you got to get the patient supine and flat. That's a basic requirement for starting CPR. So you would want to move the patient gently. Okay. Right. So this slide actually describes your hand placement technique for chest compressions. So you will put your one hand in the middle of the sternum, in the middle of the chest. It's usually at the lower half, and as you can see that the right hand, the index finger is being used to palpate the Xiphi sternum. Okay, and you put your fingers on the Xiphi sternum, place the second hand on the middle of the sternum, just above that.
Doctor,
Yes.
are you presenting a slideshow?
Yes, the slideshow is still there. I hope everyone see it.
No.
Okay.
It's not visible.
Okay. Right. I had started off. Let me see. Okay. That's.
Okay, that's good.
Okay. When did it disappear? I had started it off. Right. Can you see it now, someone?
Yes, I can see it now.
Okay, I just had a query because I was assuming that this was shared. I had started to share it right from the start of our discussion. When did it disappear?
It disappeared like maybe after the CAP, yes, after the CAP.
Okay, we've got a bit of a technical problem, but it's okay. We haven't done too much. So I'll get back to the slide. Can you tell me if the slide disappeared again?
Sorry?
Can you inform me if you do not see the slides again, so I can maybe.
Okay, no problem.
Okay, right. So we were talking about the placement of the hands on the chest for effective chest compression. So as you can see, one hand is placed at the Xiphi sternum. You localize the Xiphi sternum, the epigastric area, with the index finger, and you will place the other hand flatly on the in the middle of the sternum, in the middle of the chest at that point. Many people would use the nipples as a guide. So they say the inter-memory area, the inter-nipple area. So, but that's not a very, it's useful if the patient is flat-chested, it's a male patient, but not be very useful in females. So the landmark is palpating the Xiphi sternum with the right hand and placing the left hand above that in the middle of the sternum. Okay, you can see that the responder has interlaced the fingers of the two hands together. Okay, and the next point that I was basically trying to highlight was, please make sure that you have the shoulders over your hands. So you bend your body forward, so you have your shoulders that will be coming, shadowing your hands. So you can transmit the force through your straight elbows, through locked elbows. Is that clear?
I have a question, doctor.
Yes, Kutabi.
Doctor, let's assume that the patient is a female and the point of exposure would be difficult. So how could we localize the lower part of the sternum?
Right. I think that's a valid point. You have to understand that the Xiphi sternum, the epigastrium, can be palpated through garments. That shouldn't be a problem. Right? So you will palpate the epigastric area and the Xiphi sternum through the garments. And as you can see, that once you have palpated the Xiphi sternum, that cannot be missed. You place your hand above that, so you would easily be able to localize the location of the hand placement. Does that answer your question?
Yes, sir. Thank you.
Okay. So you look at the other side of the right side of the slide. You can see these are the wrong techniques for hand placement. So you do not, put one hand over the other in this way, perpendicular to each other. You do not close your fingers once you've interlaced them. They should be open like this. You can see that the fingers of the hand that is in contact with the chest is open, and it is the upper hand that's got a closed, fist, you could say. Make sure that the shoulders in this, they overlie. So this lady needs to bend a bit forward so the shoulders tend to overlie the chest or your hand position. In that case, you'll be able to effectively transmit compressions onto the chest, right? Okay, so again, this is a wrong technique. Hands just placed one over the other and not properly interlaced like this. Is that clear?
Yes, it's clear.
Okay, I've got an interesting question.
Question here for Scott. In case of all people, bones are fragile.
Okay, I'm sorry I couldn't hear that very clearly. If you can repeat it.
He said that in case of all people, you have fragile bones. He said that is it possible, like if we have chest compression, we might be break the bones?
Okay, I'm again. It's very difficult. I couldn't make out. Is it possible you could type out the question over here? Over here. I think.
If I break them.
Yes. Hello. Osama, I think if you repeat your question. Okay, I've seen people who have typed out their questions over here. Right. So, yeah. Okay. That's good. So I can see this. Yes. Right. So Sadi had a question. I'm sorry I didn't see him. Okay. Right. And then his question was about bones, but I think that's been answered by Afiq. Okay. Right. So if I can have the questions being typed out over here, because audio is not always clear. Hello.
Yes, sir.
Yes. Can we have the question typed out over here? It might be more easier to answer. So Sadi had a question that in old people, if the bones are fragile, what if he breaks them during a CPR? Okay. While you type out your question, I will answer to Sadi's question. We have to understand that the elasticity of the chest as a whole is reduced in elderly patients, and it's many elderly patients who require CPR. You have to still aim for an effective 2 inches compression. In unlikely cases, you could fracture ribs, but if you perform it correctly, if your compression is over the chest, not over the ribs, you would avoid this complication. But what I would say is, if you have a patient who does end up with a fractured rib, elderly patient, but you have saved his life with a CPR, I think that the benefit far outweighs the risk. I hope this answers Sadi's question. I'm still waiting for the question from Osama. Can you?
It's the same question that Sadi wants to ask. Just want to rephrase it, but.
Okay, right, excellent. So I hope the query is answered.
Yeah, he said yes.
Okay, right. So I will continue with my slideshow. Right. Okay, so we have gone through this chest compression. So I hope everyone is clear about effective chest compression. I had a question over here regarding.
Dr. Abid said in pregnant woman, what's the condition?
Yeah. Okay. Right. So pregnancy does not preclude chest compressions. Okay, and the site of the compression does not differ. Okay, Afiq, I think that answers your question.
Okay, he said okay.
Right.
Doctor, are you sharing the screen or not?
Yes, I am. Thank you for pointing it out. I think what happens is basically it just flips out. So I will reshare it again. Okay, is it back again?
Doctor, there is in the lower right, there is reading view. You can make it by reading view and no need for slideshow.
Okay.
Have you seen it?
Okay, the reading view, this is available in the Hangout?
I mean here in the PowerPoint, Microsoft PowerPoint.
Yeah.
Go in the lower bottom at the right.
Yeah.
Beside the zoom in and zoom out, there is a slideshow. There is a button for reading, and there is also another button. Have you seen it?
Yes, it says view indicator, zoom, and yeah. I've
No,
got
reading view. There's a
okay,
reading.
okay, it doesn't appear on the PowerPoint that I have. I don't know which version it is.
Okay, I think we go back to the way it was. It's visible. No need for slideshow.
Okay, right. So you would want to stop the slideshow and continue.
Yes, like this, no problem.
Okay, right. Okay, can you still see the slides?
Yes, I think. Do you all guys see it? Yeah,
I think.
they're saying, oh yes. Okay.
Okay. What I will do is, so I can see the questions at the same time. That might be more useful. Okay, is that it? I can see the comments of the audience, and I can see the slide as well.
Yeah. Okay.
Right. Okay. I had a question to everyone. What does chest compression achieve? What is the physiology behind chest compression?
Contraction of the muscles that.
Yes. Okay. So when we compress the chest by 2 to 3 inches, what are we achieving?
You're increasing the cardiac output.
Okay. And how are we doing that?
Like compression of the heart, doctor.
Okay, so traditionally in the 70s and the 80s, the mechanism behind this was thought to be basically compression of the cardiac ventricles, the left ventricle directly, the cardiac chambers. Okay, right? And this is definitely, it's logical that you're compressing the chest and you compress the heart by your chest compression, and this would pump the blood into the circulation, isn't it? But is that just the whole of it? Is there any other additional component that could be there?
To keep the circulation ongoing.
Okay, right. I think Abdul Rahman Ashkar has joined us. Okay, and he's pointed out it's the compression of the lungs as well.
Yeah.
Okay. Basically, yes. What you do during chest compression, when you compress the chest by 2 inches, you are compressing the sternum, and the heart lies directly below it. And as you can see from the slide, you compress the cardiac chambers, and the systolic valve, the aortic and the pulmonary valves allow for flow in one direction. So as you compress, you would push the blood into the circulation, into both the pulmonary circulation and into the systemic circulation. Okay, so that's part of it. Okay, but also there's another component. This was actually understood in the 80s and in the 90s, that during chest compression, when you increase the pressure in the chest as well, so it's not just direct compression of the heart, but you also compress the chest. Now, when you increase the pressure in the chest, this pressure also is exerted onto the heart, and this helps forward flow of the blood. It compresses the chambers as well. Is that clear? So it's basically compression of the heart directly, as well as the indirect compression of the heart by increase in intrathoracic pressure. Okay, right. Now I'd come to Kutaba's question in a minute, but why do we allow the recoil? It's very important that during chest compressions, we also allow the chest to recoil. We do not keep it pressed. We allow the chest to come back to its passive position. Anyone?
It's like relaxing the heart to allow the blood to go inside, and then we chest again, like we mechanical pump we mechanically force the heart to do its job, is that relaxing and contracting.
Okay, excellent. So you basically empty the heart with the chest compression, and then you need to fill it, allow it to fill up again. Okay, and
Yes.
okay, so you basically allow the heart to relax, and this relaxation of the chambers would allow flow back into the heart again. You remember that cardiac venous return depends on the negative pressure in the chest. It depends on the negative pressure in the chambers, as well as negative intrathoracic pressure. So you allow that to develop when you allow the chest to recoil. Okay, there's a question by Kutaiba. He says that the right ventricle is behind the sternum. So is it logical pressing the left ventricle behind it? Okay, so you can see from the diagram that as you compress the sternum, you're also going to depress the ribs on the both right and the left side, and this actually will affect the left ventricle as well. You will be compressing it as well. Okay, so we can continue. So you have to understand that chest compression, there is a compressive phase and there is a decompressive phase, and this means that we have to allow the chest to recoil back.
Okay.
Okay. Now, what you're doing by doing these 30 chest compressions followed by 2 ventilations at a rate of 100 to 120 per minute is you're trying to maintain the supply of blood to the tissues, and this is tissue perfusion. Okay, this graph, I hope everyone can see the graph.
Yeah.
Yes, and this graph, it clearly shows when you start off the chest compressions, the perfusion goes up, right? And it goes up and down with each of the compressions, the compression and the recoil. When you stop, when you halt the compression, chest compressions, you just see that the perfusion drops very rapidly downwards. Okay, and then you resume the compression, it goes up again. Okay, so you can see that the tissue perfusion is very closely related to the effective chest compressions. Okay, the lower graph actually shows you start off the compressions and you continue. Okay, what's the difference between the upper and the lower graph? Anyone, please?
It's the rhythm.
Yes. What's the difference between the graph A and graph B?
In graph B, there is no interruption because the compressions are going on. It's continuous.
Okay, excellent. So the message to take home from this slide is to have as little, gaps in chest compression as possible. Now you know that we have to have 30 chest compressions in a go. So you count hard and fast. You count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and you count to 30, and you do not halt before that, and you do not have interruptions in the compressions. In the upper CPR, there are multiple interruptions to the compression, and this has basically brought the perfusion down rapidly. So the message to take home from this slide is hard and fast with as little interruptions as possible. You only stop chest compressions to give 2 breaths, 2 ventilations. Is that clear?
Yes.
And I think that also answers Kutaiba's question. Would sudden stopping would compromise the perfusion? It does so very rapidly. Okay, right. So we are in a situation in which we came up to a collapsed patient. We are certain that the patient is unresponsive by shouting at the patient, "Are you okay?" We tapped the chest of the patient, and there was no response. And we observed for ventilation, for respiration for 5 to 10 seconds. There was no respiratory effort. So we confirmed that the patient is in a need of BLS and CPR. So we shouted for help. We sent someone to get the AED and activate the emergency medical services. We kneeled beside the patient after making sure that the patient, of our own safety and the patient's safety, positioned the patient on a flat, firm surface in a supine position. We exposed the chest of the patient by removing possibly the clothing, had adequate exposure, and we localized the point for chest compression by placing our right hand in the xiphisternum, localizing it, and placing our left hand, the flat of it, in the middle of the sternum. Just above that, we put the both hands together and we interspersed our fingers, and we started off our chest compressions rapidly at a rate of 100 to 120 per minute, and the idea is to do it hard and fast, and we are going to do 30 compressions. Okay, right. After completing the first set of 30 compressions, we can now proceed to the airway. Okay, right. Now, when we consider opening the airway, please make sure that the patient does not have any significant cervical injury. We have to keep that in mind. Okay, so the technique to open the airway is to place the patient in a neutral position, the neutral position for the airway itself. So you use the head tilt chin lift technique. As you can see that one hand supports the forehead, brings it, pushes it down slightly, and the other hand actually pushes the lower mandible upwards and superiorly. Okay, so once we have this head tilt, tilting the head downwards and lifting of the chin, we ensure that the airway would spontaneously open up. This technique opens up the airway spontaneously if there is no obstruction, with the foreign body. Right? Is this clear? So after doing the 30 ventilations, we open the airway by using the head tilt chin lift technique. I see I have questions over here. I'll take a little break on the questions. Okay, Atiya's question is about when we give breaths to the patient, most of the breath that we blow is carbon dioxide. How does that help the patient? Okay, Atiya, this will be explained in a minute. So we'll do that. Abdul Waris says, how many cycles should be performed? Okay, right. So this is again, I think, answered later. We are still at the start of the CPR. We have given only the first 30 chest compressions. Okay, so just bear with me. We will continue to your questions later. Okay, so right now, once we have opened the airway by the head tilt chin lift technique, we will perform the ventilation. Okay, Osama, can you make sure that the slides are there? You can see the slideshow.
Yeah, it's visible.
Okay, right. So there are multiple situations. I mean, the varieties of situation that you will be, faced with. The first one is you're not prepared for CPR at all, and you come to a patient and you're going to, give mouth-to-mouth ventilation. Okay, that's a dire situation, and all you got to do is maybe have if you can, a soft piece of cloth between yourself and the patient's oral cavities, but that won't be very helpful. Most people who have been trained in CPR and who are certified, they would be carrying a small mouth-to-mouth micro shield. Can you see that? It's usually comes in an orange packing, and it's basically a screen that you can use while giving mouth-to-mouth to a patient. Okay, right. And the technique to give mouth-to-mouth ventilation is you will pinch the nose of the patient with your right hand, and you will gently open by depressing the lower mandible and opening the airway, opening the oral cavity, and you will lock your lips over the patient's mouth and exhale into the patient's chest, and at the same time you will observe for the upward movement of the chest to make sure that you have effective ventilation. Okay, Atiya, this now coming to your question of carbon dioxide in the responder's breath. The one who's giving CPR would have mostly carbon dioxide. Okay, now normal people, when they exhale, they have 16% oxygen. Yes. So in the expiration, the exhaled breath contains 16% oxygen, compared to 24% oxygen present in the environment. Okay, so the 16% is still a life giver, so it's still effective, right? So one of the techniques to use is you use a micro shield to shield yourself from the patient's oral secretions. The second possibility is you're carrying a pocket mask, and the third one is a bag valve mask resuscitator. Okay, so this is a pocket mask. Again, this would be carried by certified BLS, responders. Okay, right? And you would be, using this. And the technique to use that is, it has got an extendable airway, and you place it over the patient's nose and chin, as this lady is doing, and you make sure that there is a seal, effective seal has been produced. So the nasal cavity and the oral cavity would be contained in this little mask, and you would be actually, blowing air through this, and this air will be going into the lungs through both the nasal cavity and the oral cavity. And finally, if trained paramedical staff and are doing this, and usually in a hospital environment, you get the bag valve mask resuscitator. I hope most of you have seen this device.
Yes.
Right. So we really don't want to, and you use the when you apply this device, you use the C and the E technique. So the C is made by the thumb and the index finger of this hand, and you can see the E is made by the lower three fingers. So you use the thumb and the index finger to place the mask over the nose and the oral cavity, over the nose and the mouth. Make sure that effective seal is there, and you use the other three fingers to actually clip the mandible in place. So you keep it in place, and both this hand will be used to fix the airway, the mask onto the oral cavity and the nasal cavity. The second hand will be free to compress the bag valve. Okay, I see that someone has pointed that there is no sound. I hope you can people can hear me.
Yeah, we all hear you.
Okay. There was a comment by one of the people that there is no sound. Okay, good. So this is clear, right?
Yeah.
Okay. So what we have started off is by giving 30 compressions, effective compressions. Count hard and fast, 2 inches. Counting them out loud, 1 to 30. Stopping, giving 2 ventilations, and again, while you give the ventilations, make sure you see the chest rise. Secondly, you allow the recoil of the lung. So you compress you expand the chest with with a breath or with the device, and then you allow the lung to the elastic recoil of the lung to take over, right? You give 2 brisk breaths and you start your compressions again. Okay, so compression. So we have affected C, which is circulation by compression. We have made sure the airway is open by the head tilt, chin lift maneuver, and B, we are giving the ventilations at 30:2 ratio, and we will continue this cycle indefinitely. When can we stop? Anyone?
As soon as paramedics come,
Yes.
and then they can take care of them if you're outside, and if you're inside, if the patient is conscious, finally, we can stop.
Okay. Excellent. Right.
I think that's all I know until now.
Okay, excellent. So basically, you do not stop until you see signs of return of spontaneous circulation. So the patient moves spontaneously or has a effective breathing effort. Okay, starts breathing. So you do not stop until you get these. The second point would be you would only stop to this 30:2 cycle once you get the AED. It's available, and you will only stop to allow the AED to analyze the patient's heart rhythm. We will quickly look over how the AED is used. You will stop once you have trained rescuers take over. So if you have paramedics arrive on the scene, and then they can take over. Or you are presented with a valid do not resuscitate order. So if it's in a hospital setting, sometimes DNR is, do not resuscitate orders are there, and you're presented with that. If you're alone and you become too exhausted to continue, naturally you'll have to stop. Or the scene becomes unsafe. So if you are in a case of an emergency, the scene becomes unsafe for you, you can stop. Now, there is a point by, I think Abdul Rahman has pointed out, that up to 60 minutes of CPR, we continue until we can declare death, until we can stop. This would be, depend on the setting, in a hospital setting, and it will depend on the cause of the cardiac arrest, on the cause of the arrest itself. Okay, right. Okay, has anyone seen an AED before?
Yes.
Okay, right. Now this has basically transformed the survival rates in BLS. We were, previously doing the chest compressions and the ventilations, but we were not actually trying to solve the problem that caused the cardiac arrest in the first place, or the collapse in the first place. Most common cause of cardiac arrest is cardiac arrhythmias, ventricular defibrillation or ventricular tachycardia, and these AEDs have actually taken care of that problem. In the West, in the States and in Europe, AEDs are available in public spaces, in public places like railway stations, airports, shopping malls. So they are available and they're very simple devices to use. I'm not sure. I think at SRC we have initiated at Salman Raji University. We have acquired 2 AED devices, and they'll be placed on each of the floors, floor 1 and floor 2. Yes, they are available. You can go down to the clinic on the ground floor, and you can actually see them. They are available. Now, very quickly, you can actually see the survival rates of public access defibrillators, the AED devices. So you can say that over here, just CPR alone has a very low survival rate of 9%. Okay, and if it is used with an AED device, it jumps to 50%. And if the AED arrives within the third 3 to 5 minutes of the cardiac arrest, the survival goes up to 74%. I mean, this is really it's a big incentive. So if you are doing CPR alone without an AED, it's only 9% the survival, and if you have an AED on the spot within 3 to 5 minutes, it's 7%. So you can imagine, and that's logical because the AEDs will terminate the cardiac arrhythmia that actually causes the shock. I'm sure if they are placed in public places, you would have people play with them. That could be a danger. I've seen Kutaiba has passed that out. Okay, now let's get on to how to use an AED. Okay, the AED has very clear instructions. We are just going to finish in a few minutes. Okay, you turn on the AED power. It has printed onto it the steps. So it says turn on the AED power. The on button will clearly be marked, and then most of these will have audio prompts. So it will say, it will tell you what to do. So you want to make sure that you expose the patient's chest. You remove any jewelry and other metal sources on the patient. It could be keys, it could be the mobile of the patient, rings. Make sure that you remove them. Okay, if they're easily removable. The AED comes with 2 pads, and they're very marked very clearly with the location. One is placed on the right side below the clavicle, on the right shoulder, on the right chest, and the other is placed just left to the left nipple. Okay, as you can see in this picture. And once you place the sticky pads, the AED will pick this up, and it will tell you that the AED is analyzing the rhythm. That's the moment when you stop chest compressions and ventilations for a few seconds. So you ask everyone to stop touching the patient, all clear, okay, and you allow the AED to analyze the cardiac rhythm of the patient. The AED takes 5 to 10 seconds to analyze the rhythm by itself, and if the rhythm is shockable, the AED will tell you that get ready for shock, okay, for shocking the patient. The AED picks up the rhythm, diagnoses it, and tells you whether it's a shockable rhythm. Next, it will instruct that the AED needs to be charged. So you will press the button for charging the shock, and then everyone will be prompted to be clear, and you can give the shock button. After giving the shock button, the AED will again reanalyze the rhythm for a few seconds, okay, and you will start the compression. If indicated, you would start the CPR again. Okay, so everyone is clear about the AEDs?
Yes.
Okay, what are the do's and don'ts when you use an AED? Okay, make sure that no one is touching the patient. Okay, so as a team leader, if there are 2 people, make sure that no one touches the patient when the AED is analyzing the rhythm. Okay, right. Secondly, you use an AED also for a patient who's pregnant. Someone might think that shocking the patient might be deleterious for the fetus. The amplitude of the shock given is too small to cause damage to the patient, to the fetus. And if the mother survives, the fetus will also survive. So pregnancy, you can still use the AEDs. Do not use alcohol to wipe the patient's chest dry when you're going to use the AED. Any ideas why not? because alcohol is flammable. It can catch fire
Yes.
with electric current. Do not touch the patient when the AED is analyzing or shocking the patient. Okay, both ways. Okay, and do not use AED if you have a fire around. So if you're in a situation in which there is a fire going on, in the emergency situation, there could be gasoline, there could be free flowing oxygen, because the AED could ignite a fire. So please remember the do's and don'ts of AED. Okay, now I think we'll just close off in a just few closing remarks. So we have the summary of the CPR. It's one thing, the major change is CAB, so it's chest compression, airway, and breathing. These are the latest guidelines. The resuscitation chart, I will just go to the current slide, maybe just enlarge it slightly. And you have D, it's doctors, ABCD. I mean, you could change it slightly, you could say doctors, CABD. Okay, now that's the latest guidelines. So doctors, D for danger, make sure that there's no danger to yourself, the bystanders, and the patient. You check the response of the patient. S is for send for help. We would go for C. You look for the start of chest compressions. Then A for airway, and then you will give ventilation to the patient. Okay, breathing, and then you would use the AED, which is defibrillation, and you will continue the CPR unless indicated. Okay, right. Anyone who thinks, what are the skills that you might need to perform a CPR?
Skills?
Yeah. What are the skills? I mean, as a medical student, as a responder. Okay, I think we have a respond. Muscle power is required. Okay, you need to be physically fit. And confident. Okay, Abdul Waris, I agree with you. Knowledge of the CPR technique, definitely. I mean, effective CPR, you really need to be well trained. You need to have good, CPR technique. We had CPR classes at SRC, and
Calm, doctor.
yes, excellent. You need to be calm. You need to be, I think, confidence and calmness would go together. You don't want to, become stressed yourself. So, and you can only do that if you have been trained well. Okay. Now, basically, we would like to look at the skills in this way. You need to have very good critical thinking. You need to have problem solving. Okay. You need to have good communication. You might be communicating with your partner in doing the CPR. You might be member of a team when you're doing CPR, and you need to have good teamwork. Above all, you need physical fitness yourself. Okay, has anyone practiced CPR in a environment, in a skills lab? Anyone? Okay, I can tell you the SRC students have done that, and it takes a lot of physical, you need a lot of, you need to be fit. We had a joke going around that if we had the student continue on the CPR for a few, cycles, they would need CPR themselves. So, so you need to be physically fit. Physicians need to be physically fit. Okay, right. I think that we come to the last part of the presentation. It's about obstructed airway. Okay. Right, so you're sitting in a restaurant, and you're having a meal, and you see someone doing this beside on a second table. They have put their hands around their neck, and this is the universal sign of choking. Okay, so anyone who places their hand around their neck would indicate that they're choking. Okay, once a person is choking, the reflex is the patient attempts to cough. Okay, and the cough impulse is there to try to dislodge a foreign body in the upper airway. It could be a bolus of food. In children, it could be part of a toy. It could be anything. So followed by the universal sign of choking, the person would be coughing, making an attempt to remove it. Okay. Now, as far as the patient is coughing, is able to cough, he might be able to speak also, maybe with a lot of difficulty. But if he's speaking and he's able to cough and he's breathing, you do not need to intervene. You tell the patient, "Are you okay? Are you okay?" And he motions, he coughs, and he says, "Oh, I'm okay." He's still attempting to remove the foreign body. And if he's breathing, do not intervene. Allow the patient to continue to cough, and that's the best effective way to bring out the foreign body. If the patient stops coughing, or the patient becomes cyanosed, is not breathing anymore, and is unable to talk, this indicates that the obstruction is enough to stop the patient from breathing. It's not allowing the patient to move the air in his airway. That's when you will intervene. So you stand beside the patient and you give 5 thumbs at the back of the chest. Okay, 5 brisk thumbs in the interscapular area, 5 brisk thumbs. Please make sure you don't hit the patient hard enough, allowing to topple. It should be brisk, but not so much that the patient would topple while standing. Okay, so you give 5 brisk back thumbs to the patient. This would sometimes remove the foreign body effectively. If this doesn't do the job and the patient continues to be, has difficulty in breathing, is unable to cough, is unable to talk after your precordial thumbs, you will perform the Heimlich maneuver. Okay, and the position for that is you get beside the patient, behind the patient. Of course, you tell him what you're going to do, and you place your first hand with a fist. You make a fist, and you place the thumb of your fist in the just below the xiphisternum. This will be somewhere between the umbilicus and the tip of the sternum in a patient. And your target is basically you want to press not the chest directly, but you want to press the diaphragm, lower diaphragm. Okay. You put the first hand in the xiphisternum, and then you use the second hand to support it. Okay, and you give inward rapid upwards and inward thrusts. Okay, and this would basically compress the lower diaphragm and increase the intrathoracic pressure abruptly, and would push on the obstruction, whether it's a bolus or a foreign body, and this might remove the foreign body obstructing it. Okay, so you recognize the choking. You give thrusts above the in the area of the epigastrium. Okay, you give 5 thrusts. Okay, you continue this, and if the patient can force out the object, or the patient can breathe and make sounds, or the patient could stop breathing or stop responding. So you could have 3 situations once you give them the Heimlich maneuver. The object is forced out, the person can stop, can breathe and make some sounds. Okay, that's a good sign. Or the patient would stop responding and collapse. And if the patient collapses, you of course follow up with a CPR, which is part of the BLS. Okay, right. Any questions?
No, Antonio.
Yes, please.
Doctor?
Yes.
If, in case that if the patient is alone and no one is around him and he got shocked, is there any, sorry, I just got back from lag, but I'm asking this, I don't know if you answered it or not, but if someone is alone and there's no one around him, how do we solve, and he got shocked by something, how do we act on it, and how do we act, or how does he act on it in that case?
That's an excellent case. I think the first response would be, if you're alone and you would naturally, you would have the universal choking sign, you would be holding your neck and attempt to cough, okay, as hard as possible. So coughing would be useful sometimes. Now, interestingly, you can give yourself a Heimlich maneuver, okay. So I think that's what you're trying to allude to, is you basically, if you are in a position where there is a chair available or the edge of a table, okay, you would actually substitute the chair or the edge of the table or the as your responder. So you would place the edge of the table or the top of the chair in your epigastrium, and you would push against that in a brisk way, and this would be as if you're simulating a Heimlich maneuver by a responder. Does that? I think that's what you were pointing to. Yeah, I think Kutaba's also pointed that out. You do it on a chair. Okay, so you can give your Heimlich maneuver to yourself using a chair. Okay. Right, so we have to understand, we all need to learn BLS. It saves lives. We need to teach BLS. This would save lives. And we want to train in BLS. Remember that BLS requires hands-on training. A presentation like this would just introduce you to the concepts, to the techniques, but it's a psychomotor skill that you need to basically learn in a skills lab. with the presence of maybe mannequins with simulated environment. You would have a trained staff who would guide you. So this presentation would basically will guide you to understand the importance of BLS and the physiology behind it. I have two questions. Okay, Abdul Waris has asked, how do you okay, I'd like to answer the question by Abdul Waris first. Talked about choking a child. Okay, I had looked at the presentation and I thought that we didn't have too much time if discussing child CPR. Okay, but if you're talking about an infant, you would basically support him, on your forearm with the face supported by your hand. So the child will be prone on your forearm, and you would bring your forearm down. So the head end is lower than the feet of the child, and you could actually thump the child's back repeatedly. That can basically, yes, that would take care of the foreign body. And if it's a child above the age of 12, the technique is the same. So that doesn't differ too much. Okay, Sadi has a question saying, by giving breath, is it not going to push the item further inside? Okay, now Sadi, interestingly, in previous CPR guidelines, there was you made an attempt to remove an expected foreign body by doing a finger sweep method. Okay, and actually that's been thrown out because the finger sweep it can push the object down, but breathing, you do not know if there is a foreign body inside the airway, right? And you cannot be sure of it. So unless you have seen someone swallow something and choke, you would still not worry about that. So you will continue, you would give the breath in that case. Okay. Okay, I think we have a prompt by that our time is up. Okay, right. So
move on, but we maybe minutes remain.
Okay, I'd stop the sharing. We had a bit of a problem with the audio. I think if we can have our colleague repeat it again, Mr. Osama, if you can repeat what you've just said. We've had some issues with the audio.
So we have, I think, 10 minutes remaining.
Okay, we have 10 minutes remaining because I had I think the medical student, someone who's labeled as a medical student, said its time is up. I don't know if that's an issue. If that's not an issue, I think we can quickly have a look at a useful video. Okay, so if I can again go back. So I would go back to the sharing. I would like everyone to,
Doctor, by the way, can we have the PowerPoint presentation?
So I think the doctor went away. Ladies and gentlemen, we thank you for the doctors.
Yeah, I had a bit of a problem. I just got just disconnected. So let me just go back to the sharing. I would want you to watch everyone, and we can end by just watching a short video that would be useful. So,
Doctor, just before you start, can you have the PowerPoint presentations?
yes, I can post it. We could devise a way that so we can you can have it. It's not a problem.
Thank you, sir.
So I'm trying to share the screen. Okay, I've got it now, and let me see if it works this time around. Okay, it seems to be working. Right. So.
How to perform CPR for an adult. Survey the scene, make sure the scene is safe to approach. Gently tap and ask, are you okay? Are you okay? Are you okay? They don't respond. Tell someone to call 911, get the AED, and come back. Check the pulse on the side closest to you for 5 to 10 seconds. 3, 4, 5, 6, 7, 8, 9, 10. No pulse. Start CPR. 30 compressions. 4 and 5 and 6 and 7 and 8, 9 and 10, 11 and 12, 13 and 14 and 15 and 16 and 17 and 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Tilt the head back and give 2 breaths. Perform 5 sets of 30 compressions and 2 breaths. How to perform.
Okay, so that's one of the videos. There's a lot of video. I think this was very few videos actually have incorporated the updated guidelines. So that was a bit of a difficulty looking for the CAB videos, but they're there. And I think that is anyone interested in seeing a patient choking? So maybe this would be useful.
Keep coughing. Are you choking? Someone call 911. He's choking. May I help? I know what to do. Lean forward.
When a conscious person can no longer cough, speak, or breathe, he may be choking. We give back blows and abdominal thrusts to help push the object out of the airway. Do not try this on your partner. Ryan is only simulating the back blows and abdominal thrusts. What we can safely practice with our partners is how to position ourselves in relation to the person who is choking and how to find the correct hand placement for giving back blows and abdominal thrusts.
We explain how to save lives with CPR. This is Maria. Her friend Peter has collapsed and his heart has stopped. Maria is shocked. She has called an ambulance, but what can she do in the meantime? Maria has seen heroes save people in the movies, but how does it work? If the heart stops and the brain doesn't receive oxygenated blood, there's danger of brain damage. Cardiopulmonary resuscitation is an emergency procedure for keeping oxygenated blood flowing around the victim's body. Cardio means heart in Latin, and pulmonary involves lungs. Unlike in films, it isn't intended to restart somebody's heart. That usually requires an electric shock from paramedics. CPR involves repeatedly compressing the chest by about 5 centimeters at a rate of around 100 beats per minute in order to replace the heart's rhythm. Maria could also breathe into Peter's mouth or nose, though this isn't as important unless you're a trained professional. But there are some complications for Maria to keep in mind. Tearing of the liver can occur, as can bruising of the lungs. Rib fractures are relatively likely, but much better than the alternative. Without CPR, Peter would likely die. Maria is relieved that she now knows what to do and can increase Peter's chances of being revived. The ambulance arrives quickly and successfully saves his life, thanks to Maria's efforts. With CPR, you don't need to be a hero to save lives.
Okay, right. I think if we have a few minutes left, we can have, if there are any questions, any queries.
Guys, do you have any questions?
Doctor, I asked a previous question, but I couldn't hear it because it was the voice went out.
Yes,
it was about when we give breath to patient, we blow mainly carbon dioxide.
Yes,
how does
yes.
that help the patient?
Okay.
Could you repeat?
Yes, I could repeat the answer. Actually, as I mentioned previously,
Yes.
in a normal person, the exhaled breath, the breath that you exhale has 16% oxygen. Okay, the environment has 24% and or 23%, but you are exhaling 16% oxygen. So that's useful. It is a lifeline for the, even if you use that exhaled air, it still has oxygen in it.
Mm-hmm. Okay. Thank you.
Okay, right.
Or guys, if you do you have any other questions? Anyone?
Okay, it's good to see that everyone is clear, but I would again reiterate that BLS is a psychomotor skill. It involves physical technique. So, you know, introductory sessions, etc. I would encourage everyone to try to get trained and try to become certified. I think now the Saudi Heart Association is even allowing medical students, paramedical staff, and people from the public to get certified. So you know, it's a privilege and it's a, you know, responsibility of the medical you know, staff, anyone, students, nurses, doctors, to be, you know, able to save lives. If you, God forbid, are in a situation in which someone has collapsed and people know that you're a medical student, they'll naturally turn to you for help, and it would be you know, very useful to know this skill. I would encourage everyone. I would encourage everyone to get in touch with your local, you know, BLS providers. They're usually the CME departments of Ministry of Health hospitals, where you can register and you can get yourself certified.
All right. In this lecture, we will end by saying thank you for the valuable lecture that you gave it to us about the new facts and updated information about the basic life support. Thank you very much for using your valuable time to keep us in mind that basic life support is thing which is a fundamental thing that we can save lives. And also I would thank the audience, from Abdurrahman to Asma to Atiyah to Qutayba to Hassan to Saadi to Afif and Abdul Warith. I hope that you all get benefit from this lecture, and good luck, and that's it. Wassalamu alaikum wa rahmatullahi wa barakatuh.
Okay, everyone. Assalamu.